The CEO of UME Health in Harley Street, and I'm pleased to welcome you here this evening to our webinar on the swollen knee, its diagnosis and its management. Joining us today, we have Chinmay Gupte, who is a consultant orthopedic surgeon and associate professor in knee and trauma surgery at Imperial College London. Chinmay has got an extensive CV. He's on the executive of the British Knee Society, where he's involved in the agenda setting for meniscus tears and knee replacements. He's on the British Orthopaedic Association Research Committee, running projects into sports injuries, and also training undergraduate and postgraduates in surgery. He's a past president of the Royal Society of Medicine Orthopaedic chapter, and also has extensive knowledge of sports injuries, having been a professional cricketer himself in a previous life. In addition, we've also got Dr. Cynthia Gupte with us, who is a consultant radiologist and honorary senior lecturer at Imperial College London, where Cynthia will discuss the radiology of the swollen knee, including how to interpret reports. Following their presentations, we'll do a quick question and answer session where you'll all have the opportunity to submit your questions in the Zoom chat, and we'll hopefully be able to get through all of those. So without any further ado, I'm going to hand you over to Chinmay, and I hope you enjoy the webinar. Chinmay.
Rory, thanks very much. Great pleasure to be here. Welcome, everyone. And from the registrations, I'm assuming that most of you are general practitioners. Please place in the chat if you have other specialisms, and clearly if you have any other questions to do with the webinar, please do liaise with us through the chat. So one of the most common presentations that we will find of knee problems in general practice and indeed in the emergency department is someone who comes in with a swollen knee that's really bothering them, causing them pain and disability. So we're going to go through the workup and the possible diagnosis, and I'm going to touch upon some management strategies. In 20 minutes, we're going to struggle to get through everything comprehensively, but I'll do my best. So here's a swollen knee. You can see on the arrow where the water comes back. And we're going to go through the basics of why knees might swell up, the history and examination, which investigations to do and when to refer to a specialist or the emergency department, and we'll touch upon the management of osteoarthritis, meniscal and sports injuries. It's best to think about a swollen knee in particularly anatomic, the functional anatomy sense, but also to get a really good history and examination. Think about the patient in front of us and then work out some pathologies that might fit with their clinical picture. Anatomy is important. It's something that I learnt, I wouldn't say in medical school, because I pretty much hated anatomy in medical school, but particularly when I was doing my fellowship examination, and especially when I was doing my PhD in knee biomechanics a good 15 years ago. If you understand some of the anatomy of the knee, you can work out what might be wrong, especially when the patient starts pointing to one part of the knee. And if we just go from superficial to deep, skin, fat, and bursa can all get inflamed. So you can get cellulitis or bursitis. There are several nerves around the knee, and you can get neuromas or damage to nerves from direct trauma. So we mustn't forget that. Then we start going into the more chunky knee stuff, including structures that are outside the capsule, like the patellar tendon, the iliotibial band, the collateral ligaments, the hamstring tendons, the gastrocnemius and quadriceps tendon, and the popliteus tendon. These structures exist in the main outside the capsule of the knee joint. And then inside the capsule is the real clockwork of the knee, which we all know about, including the menisci, the cruciate ligaments, the chondral cartilage that lines the bones, and the bones themselves, and a pad of fat that lives just behind the patellar tendon. All of these structures can have pathologies that present with a swollen or painful knee. Now, when you ask a patient which part of the knee hurts, probably half of patients will point with one finger to the part that hurts, and the other half will say, oh, it's kind of around the front or around the back. But if they, in that half that point with one finger, you can then start thinking about what are the structures in that area and then cross-referencing that with the age of the patient. So for example, anterior knee pain is classically an extensor mechanism problem, which could be either the quadriceps, the patella itself, the patella tendon, or the insertion of those tendons into the tibia. So you get Osgood Schlatters in an adolescent, whereas you might get in a middle-aged person patellofemoral osteoarthritis, or certainly chondral thinning of the patellofemoral joint. Medially, obviously the medial meniscus, the medial collateral ligament, the medial hamstring tendons. And again, I'm not going to go through this whole table, but you can see that you can start developing a diagnostic network based on just where the patient is pointing and their age. We will obviously give you handouts at the end so you can scrutinize this table and perhaps add some new diagnoses to it as well. Pathology. Well, swelling can either be acute following an injury or chronic or acute on chronic. So I've given you some percentages from a study there. And the key thing is, if you have an injury and the knee is swollen, by definition, there is a structure that's damaged. And it kind of behoves us now as doctors, and particularly as a specialist for me, not to just say you've sprained your knee. That's a very 1980s diagnosis. We need to understand what bit of the knee is damaged, even if it is a partial medial collateral ligament tear, which you could say was a sprain. So that's why we need to think about the structures and the pathology. If it's a chronic issue, then it's more likely to be an inflammatory component, or one of the red flags is really infection or tumor, although these are not vanishingly rare, but certainly uncommon. Important to take a history. The MRI will only inform a really good history and clinical examination. And clearly the history of injury is important. Where is the pain? When do they get the pain? What makes the pain worse or better? Associated symptoms, locking, giving way, swelling. Disability that the symptoms result in. So some teenagers or young adults will say, well, I've got no problem with a knee, except when I go and play netball or football, because when I twist, I can't trust it. And that's the only symptom they'll have. Whereas an elderly patient may have a walking distance limited to 50 yards. They may have stair pain, pain at rest or at night. So it's really important to understand the associated symptoms and the disability. And then particularly in younger adults, the history of childhood problems. And I never forget rheumatological causes. We do sometimes pick up particularly sort of inflammatory arthritis, HLA-B27 positive spondyloarthropathies. So it's important to try and get a history that might suggest that. And what treatments have they already had? Have they had physiotherapy? If so, what sort? Have they had injections, or have they had previous surgery? So here's an injury. The history of the injury is quite important. Most knee injuries actually non-contact, awkward landings like this one. And it's important to know, could they play on? Because then it's unlikely to be a big ligament injury. It's more likely to be a meniscus tear. Often with meniscus tears, the swelling or the pain occurs later on, 24 hours or so afterwards. So it gives you a little bit of an idea of the severity of the injury. Examination, I'm not going to, this is medical stool stuff, so I'm not going to labor this too much, but suffice it to say, it's really important, whether you have a scan or not, to do a good clinical examination, to elicit these signs, because sometimes, as you'll hear, the scan report could say, well, there might be a partial tear of the anterior cruciate ligament, or perhaps there's edema in the ACL, but it's not torn. And then the clinical examination becomes really important, because you need to know not just whether there is some radiological pathology, but whether there is actually a consequence to that in terms of the stability of the knee. And here you have the Lachmans on the right and the anterior draw on the left. So then you've got the patient in front of you, taking a history examination, you know there's something wrong. I know I'm teaching my grandma to suck eggs, but we're going to try and give you a context of when to do x-rays and when particularly scans are indicated, and sometimes when they're red herrings. Again, as I said, I never forget about inflammatory causes with ESR and CRP, urate for gout, and vitamin D. I think is extremely important for two reasons. First of all, it can present with pathology. In fact, I saw someone in the clinic as a third opinion only last week who had been listed for a very complex knee operation for anterior knee pain. And they'd already seen a rheumatologist, but I don't think anyone had done a vitamin D, and her vitamin D was 12. And that will give you all sorts of problems. And vitamin D is actually not a vitamin, it's a hormone. So that's number one, is to get the diagnosis. Number two is I will not operate on anyone with a low vitamin D, because I think there are many studies now showing poor outcomes if you don't correct the vitamin D preoperatively. Weight-bearing views are very important. So if you do request x-rays, if the patient can stand, please request them AP lateral and skyline weight-bearing. And you can see the difference here in the joint space in the lateral compartment from someone who's lying down on the left compared with standing up weight-bearing on the right. It's also important to try and get some idea of the patellofemoral joint. So this is a curator in one of the Natural History Museum, and she has anterior knee pain, and the report for this would come back as mild to moderate degenerative changes. But when you do a skyline patella view, you can see that her skyline on the right shows severe patellofemoral osteoarthritis. And it's really important to get those x-rays to get a full diagnosis of if you're suspecting arthritis. MRI scans. Well, you know, I scan most of the patients I see, so I'm not by any means suggesting that MRI scans shouldn't be done, but it's really important that they're done in the right context. So in general, if a patient is over 70, you want to get x-rays first. And if those x-rays are normal and you can't find a bony pathology, then get an MRI scan. It's kind of the opposite for younger patients. So, you know, one of the things we discussed at the British Knee Society is the epidemic of adolescent and young adult severe knee injuries, whether that be anterior cruciate ligament, meniscal tears, or osteochondral fractures, and the fact that they are picked up very, very late on. And there are some guidelines coming out very soon that suggest that particularly in adolescents and children, if they have an injury with a swollen knee, it behoves all of us to request an MRI scan, because they won't have a fracture, but they will have some structural problem in the knee. And it's important to diagnose that early and treat it early, because the outcomes are extremely good if you treat it early and not so good if you treat it late. Referral to specialists. Well, if you suspect a ligament or meniscus injury or the presentation keeps coming back to you with the same problem, red flags in particular: rest pain, night pain, fevers, night sweats, weight loss. Previous surgery, I think it's quite difficult to tease out problems from previous surgery, whether it's an anterior cruciate ligament in reconstruction or a total knee. It's slightly different if they've had a quick clean out and a meniscectomy, but particularly previous surgery and the patient has persistent symptoms. And if there are multiple knee pathologies on an MRI scan, which they often are in patients over the age of 65, it's quite important to tease out which pathology is actually the pain generator or the problem, rather than try and treat all of them. I've listed a few causes of painful total knee replacement there. I mean, that's a whole talk in itself, and I know time's moving on, so I won't dwell on that too much, but perhaps you might want to go back to that. And similarly with the anterior cruciate ligament reconstructive knee, there are lots of reasons why patients who are post anterior cruciate ligament injury may have symptoms of either pain or instability, and I've listed them there too. We're always interested to see them. As I said, I get quite a lot of second and third opinions, and I find it a nice diagnostic challenge to find something that perhaps other people haven't. Acute knee injuries, you can divide them into low energy, high energy, and acute on chronic, and we'll just go through some very straightforward examples. So here's a ballerina, twisting injury. She carried on dancing, gradual swelling, but lateral pain, and sometimes the knee feels like it's catching or locking. And the differential here is meniscus tear, possibly a cruciate ligament injury, possibly an osteochondral injury, but the meniscus tear is at top of the differential. And you can see you will get some further expansion on this. This is an MRI, sagittal MRI, normal meniscus on the left and a torn meniscus with that high signal on the right. And it's important to catch these early, because more and more we want to save the meniscus, not remove it. And the earlier you catch it, the better the results are of repair. So coming on to how you manage meniscus tears, not all of them need surgery by any stretch. So I probably see 10 meniscus tears in my clinic a week, and I would only suggest operation for about 3 patients out of those 10, because well, as I said, we've now got some guidelines from the British Knee Society, and they're evidence-based as well as peer-reviewed and expert consensus. And you don't operate on all meniscal tears. In fact, you try not to operate on most of them. Only if the meniscus tear is symptomatic for greater than 3 or 6 months, or within that 3 or 6 months, the patient has locking or giving way, or if there's a displaced tear on an MRI scan. Those are the indications for operation. So some patients do come back with 6 to 12 weeks of conservative management requiring an operation. Conversely, a meniscus tear in a child may require an early operation in order to stitch or save the meniscus. So it's very, I mean, I've listed the algorithm there, but it's quite a complex decision, and sometimes it's not an easy one. And in fact, I'm going to take a patient I saw with a complex lateral meniscal tear who's only 16. I'm going to take it to our national multidisciplinary conference because I'm not sure whether I need to operate or whether I need to get some radiological guided injections for him. So, you know, these are complex issues, but when we do operate on meniscus tears, our default these days in patients, and by the way, this age is getting older and older as I get older, in patients less than 50, is to try and stitch the meniscus back rather than, you can see here, rather than trim it away. I'm just going to run this video a little bit further, and you can see that meniscus is now going to be taken away, and that's going to leave a huge deficit in the knee, particularly in regards to reducing the contact pressures between the bones and shock absorption. So we're really trying to avoid that if we can. So case 2, footballer landing in external rotation, non-contact injury, can't trust the knee, that he was unable to play on, not dance on, and couldn't trust the knee and was having trouble pivoting when he was playing football, and the knee's giving way. So really, this is a classic anterior cruciate ligament injury. There could be lots of other reasons, but that's number 1 on the list. And this is a normal anterior cruciate ligament. This is one that has been torn. You can see this is the other side. So this is a left knee this time. And you can see on here, a normal ACL compared with a torn ACL. Now, again, not all anterior cruciate ligament injuries require reconstruction. And the algorithm for that is particularly how old is the patient? What would they like to do in life, in particular pivoting sports? And do they have other structures involved in the injury, particularly the menisci? So if the meniscus is torn, you want to try and save that meniscus. And if you're going to save the meniscus, you want to stitch it. If you're going to stitch the meniscus, you want to reconstruct the ACL so that you have a stable knee for the meniscus to heal in. So those are the kind of decision pathways that we go through with anterior cruciate ligament injury. However, in children, all anterior cruciate ligament injuries should be reconstructed early, not late. We know that if they're not reconstructed early, they're menisci tear and they have poor outcomes. And this is a new graft going into the ACL. So kneecaps can dislocate. This is one that obviously stayed out, but most kneecaps dislocate and go back in. And it's quite difficult to diagnose sometimes unless the patient tells you they're dislocated. And when the kneecaps dislocate, they rip this ligament known as the medial patellofemoral ligament. And then the patient, if they keep dislocating, and by the way, most patients get one dislocation and then they get better after. About 80% of patients don't have a recurrence. But some of the, particularly the children, the young adults, they have some predisposition, as this young girl does. The right knee is just maltracking. The left knee has actually dislocated many times. And I think you could see earlier that the left knee was very unstable, the kneecap. Now, what we've worked out over the last 20 years or so is what is the underlying pathology. And we've now worked out where methods of stabilizing the kneecap, and it's extremely successfully. So recurrent patellar dislocators require an operation, and it's a life-changing operation for them. Some of the patients I've operated on haven't even been able to walk. Their patellae are so unstable, and then when you stabilize the patellae, it is life-changing. So we just need to figure out who needs the operation and who doesn't. So this young lady was assaulted by her boyfriend, and he stamped on her, went to casualty. This isn't actually a photo of her. This was lifted from the net, and I just wanted to say the right approach here, lateral, superior lateral approach. So if you do inject knees or aspirate knees, the approach is right. However, really poor aseptic precautions, no gloves, very poor preparation, no drapes. This is someone who's going to get septic arthritis from bugs being injected into the joint from this aspiration. But aspiration can be very therapeutic if the knee is really, really badly swollen. Taking that fluid off is like decompressing a really tense balloon, and patients really appreciate it. This lady had fat on aspiration. You can see a fat fluid level here, and she had a vertebral plateau fracture. And sometimes these are missed in the emergency department. And that was actually her CT, and we had to reconstruct the plateau with, as you can see, metal. You will probably not see these so much, but you may see them post-operatively. So this was a patient who came off his moped, and if I say to patients, there are 5 ligaments in the knee, there are 2 collaterals, the 2 cruciates, and something called the posterolateral corner. And this patient, the only ligament that was intact was the medial collateral ligament. All the other ligaments were torn, and we had to reconstruct all the other ligaments. But these patients will have some issues afterwards, pain or stiffness or some instability, and they've already also damaged their knee quite badly. The other group of injuries is repetitive microstrain, and in particular, I'm thinking of patellar tendonitis. I'm thinking of iliotibial band syndrome and anterior knee pain. Again, it's a talk in itself. But suffice it to say, the patient needs a good diagnosis and often really good physiotherapy. And we do have some treatments beyond that that have some evidence base. So for example, PRP, platelet-rich plasma for tendonitis, has been shown to be reasonably efficacious. Shockwave therapy for iliotibial band. So there are some minimally interventional therapies, if you like, and very rarely do these patients ever need procedures. Osteoarthritis. Well, this is an arthritic knee. You can see that the joint space is completely gone in this patient. Lots of different ways, and patients ask, most patients come now having been equipped by the internet, and they'll say, right, what can I have? Can I have injections? How can I afford to avoid a knee replacement? And here's a kind of decision tree. It really depends on the patient, their age, their activity level, their disability, and the kind of arthritis they have. So if, for example, there's one compartment that's injured, you might want to do a unicompartmental knee replacement. However, if that patient is 40 and their compartment is not injured, sorry, arthritic, they might be asking, actually, look, I want to avoid a knee replacement. I'm only 40. They might be asking for some intervention beyond physiotherapy. And that's where I think the injectables have a role. And here's a spectrum. So what I say to patients is, look, there are really 3. I'm not going to talk about the 4th very much because I don't really think we've got enough evidence for it. But the first one is steroid has been around for 50 years, really cheap, but probably damages your knee if you have too much. The next is lubrication gel. We don't really know how it works, but there are some studies that show reasonable efficacy in about 60 to 70% of patients for a few months, and they're not that expensive. Then the next is platelet-rich plasma with or without lubrication gel. And I've done quite a lot of research in this because I was pretty skeptical about it in the osteoarthritic patient. I think there is a role, it's a limited role, but it's a holding measure. And if patients are keen on paying for a treatment, this is the one to have. not the stem cells. Stem cells are incredibly expensive. Most of the treatments you're seeing in and around London are not stem cells at all. They're fat cells with very few stem cells in them. And, you know, it's a pretty penny, particularly for the people doing it. But I don't think that there's good enough evidence base to warrant that kind of expense. But PRP, I think, is reasonable in certain patients, but they're holding measures. So just to conclude, really important to take a good history and examine the patient and think about the patient in front of us. Think about anatomy, biomechanics, and also psychology. These patients have, you know, they particularly, for example, children who haven't been able to play sport, they have a real issue with the quality of their life. And it's important to understand that. And surgery, we just need to pick the right patient at the right time and do the right operation in the right way. And it's not an easy ask, actually. And there is some roles for injectables as holding measures. Thank you very much. I treat only knees, and I treat knees from childhood to adults. I treat quite a lot of, 50% of my practice is adolescent, 50% is adult, and of the adult practice, 50% is soft tissue and ligaments in injuries, and 50% is knee replacement and unicondylar knee replacements, which I do with robotic assistance now. We will be slightly changing the website. We've given you 3 websites there. So I'm going to put a lot of papers, a lot of my presentations on the websites, and I'll be doing some YouTube videos as well, which might help for you when you consult with your patients. So I think I'll stop there. Thank you very much for listening. Shall we move on?
Thank you, Chinmay. I think let's move on to Cynthia. So
Thank you.
Can you hand across to Cynthia?
Thank you, Chinmay, and thank you, Rory. I'm going to attempt to share screen.
Chinmay, you might need to stop sharing. Can you stop sharing on your side? There we go.
Try.
Are you able to see that?
Yeah.
Yeah, perfect.
I can see it on your camera.
Okay, so let's kick off. So in the next 20 minutes, I am planning to go through the common imaging tests that we utilize to assess the swollen knee, and to give you a bit of background on those modalities, so plain films, cross-sectional and ultrasound. And I'm going to run through a series of real cases and the appropriate indications for requesting which test when. So let's start with knee radiographs. So these are commonly done usually in the context of either in trauma or in the outpatient clinic. So in the case of trauma, to rule out a fracture, or if your patient has focal bony tenderness, if they're not able to weight bear, if they have a new swelling or new joint effusion. And in the outpatient setting, if you suspect arthropathy, be it degenerate or inflammatory, to assess for fracture healing, and also if they have had surgery and to look at prosthesis and complications of prostheses. So one thing to mention, that even in this modern age of cross-sectional imaging, it's still very valuable to get plain films. As a rule, radiologists like looking at plain films, and there's a huge body of expertise and body of knowledge of the plain film appearances of common pathologies. And we like to always refer back to it, even when we're looking at an MRI or a CT, because it gives us reassurance. And there are some pathologies which, in fact, for example, say a tiny bony avulsion injury in situ, it can be very helpful to have a plain film correlation. So I thought it would be useful to go through some basic anatomy on plain film. And I'm sure some of you, or most of you, probably have digital access to the imaging for your patients. So,
wait. Hello. Hi.
So we're just looking at the plain films and looking at the anatomy on plain films. And because I'm sure most of you probably have digital access to your patient's imaging. So I just thought I'd run through some basic anatomy, but also look at some plain film review areas. So just looking at the lateral film here, you've got the distal femur and the proximal tibia, and certain key areas that are quite useful to look at on a plain film. So you've got your patella here, fractures, avulsion injuries, the patellofemoral joint space. Also the extensor mechanism you see actually quite well on a plain film. So look at the quadriceps tendon, it should have a crisp posterior margin. If the patient has an effusion, this is where you're looking for. The patella tendon here, this is the tibial tuberosity. Other review areas are look at the articular margin. So if you're querying a tibial plateau injury, posterolateral corner, the fibular neck, the fibula here, don't mistake that for a ossific loose body. And then going on to the AP view, you've got another view of the patella, check for a fracture or a bipartite patella. You've got the distal femur, and then you've got the medial and lateral femoral condyles. Look at the articular margin, looking for a tibial plateau fracture. You may see a subtle sclerosis, which may show some compression of the trabecular pattern, which may be another indication of a tibial plateau injury. The joint spaces, so medial and lateral compartments, check your fibular head and your neck. And the other region is the intercondylar region, because there are soft tissue attachments in this region. So look for an avulsion injury in that area. The other thing to look for is any subchondral lucency on the plain film, because it may be an indication of an osteochondral injury. So this is just a diagram showing you the soft tissue structures. So the tibial foot plates of the cruciates, as well as there are root attachments of both medial and lateral menisci. So just something to think about when you're looking at the plain film and what things may have avulsed off. So in the setting of trauma, the films that you would ask for are an AP and a horizontal beam lateral. So this is a shoot through view. And the reason why you look for that, ask for that, is because you're looking for a lipohemarthrosis. So in the setting of trauma, what you're looking for is this fat fluid level, and that occurs because the fracture here that leaks bone marrow. Fat is lower density than blood, and so you end up with this fat fluid level. And if you have a case where you have a lipohemarthrosis but you can't see a fracture, you need to chase where is that fracture and do another imaging test. In the setting of the outpatient clinic, as Mr. Gupte mentioned, you'd ask for a series, and you must have weight-bearing radiographs, because that really can assess the actual real load-bearing joint space. And if the films are not labeled as weight-bearing, you'll have to assume that they are not. The other film that's often done of the knee is the Rosenberg or the tunnel view, which gives you an even better view of the articular margins. And also, as was mentioned earlier, the skyline view to look at the patellofemoral joint. So this is a real case that was done this year. It's an orthopod wanting to know about the position of the prosthesis. They've had a unicondylar done, and we're looking for periprosthetic fracture or lucency, and if there's any malalignment or subluxation of the prosthesis. So MRI essentially is to look for internal derangement of the knee. So if you're querying a chondral, meniscal, or ligamentous injury, go for an MRI. If you're querying a bone marrow lesion, also MRI is the best test. And if you have a soft tissue mass lesion, which is more than 4 centimeters, so beyond the size of the ultrasound probe, or is indeterminate on ultrasound, then MRI is the best test to go for. Just a review of the imaging terms that you may see in a report for your patients. Axial is transverse section, coronal is going through the patient from front to back, and sagittal is going from side to side. And this is a real image slices through a knee. So these are sagittal on the left, coronal in the middle, and axial on the right. And these are what we call PDFS sequences. So the signal from the fat has been nulled, and so anything bright is fluid. So an effusion on the far right is bright, and we use this sequence really as a workhorse sequence in MRI imaging to look at. It gives excellent detail for the menisci and the cartilage, and also if there's any fluid or edema. The other sequence that we must have is a T1 sequence, which is to assess the bone marrow and also to look at soft tissue lesions. There are other sequences that we do if we are querying hemorrhage, such as gradient echo, and sometimes we give contrast if we're querying a mass lesion. CT we use primarily to characterize the bony anatomy in more detail. If we have a tibial plateau fracture, we're questioning if there is a tibial plateau fracture in a patient, that there is a lipohemarthrosis on the plain film, we would do a CT, and the surgeon often requires this to plan the type of fixation that they'll perform. Sometimes if we're querying a loose body, which we can see on a plain film, but we couldn't see on an MRI, but we're still not sure, CT is very helpful. Telefemoral maltracking, and also in a specialist center, it's used to guide a bone biopsy. Ultrasound in the hands of someone with an MSK skill set is absolutely, it's fantastic to assess the superficial soft tissues. It's very quick, there's no radiation involved, so it's very good for kids and for pregnant women, and it's usually easily available. So if your patient or yourself can actually put a finger on the local area where it hurts or it's swollen and there's an actual lump there, a discrete lump, ultrasound is a very good first imaging test. As was mentioned earlier, the extensor mechanism, because it's superficial, or any swelling that's around the front or the back of the knee, ultrasound is very good because these are all superficial soft tissue structures. And also the ligament, collateral ligament complexes either side, and also the tendons on either side can be assessed with ultrasound. But what it cannot do is determine or exclude internal derangement of the knee. That is not possible. You may see an extruded meniscus, but you cannot really give any more detail about the type of tear. And for that, you will need an MRI. Ultrasound, of course, also provides an opportunity for intervention, whether it's for aspiration or injection of steroid or PRP. So let's move on to some cases. So this one is a 40-year-old slipped and fell on some rocks and presented with a knee swelling in casualty. And you'll notice on the lateral view that there is a soft tissue swelling at the front of the knee. There's no fracture on these films. And so the appropriate imaging test to assess that further, the patient's weight bearing and is not locked, is to do a focused ultrasound. And what that showed was a prepatellar soft tissue swelling, which had some debris in it and probably some blood products, and it's probably a hematoma. You wouldn't need to follow that up if it resolves in the appropriate clinical manner. And you know, that's a hematoma, and that will resolve in time, and nothing else really needs to be done. Another soft tissue swelling, popliteal fossa, very common. So this is what we call more commonly a Baker's cyst. it's neither really a true cyst or a bursa. It's actually a cystic swelling, which is a communication between the posterior joint capsule and then the bursa between the medial head of gastroc and semimembranosus. And it's actually this speech bubble appearance that confirmed the diagnosis for us on ultrasound. They're very common. They're associated with OA or inflammatory arthritis, in which case we may see some synovitis on ultrasound, and it can be associated with trauma. The other differential to think about, and which is why it's quite useful to do an ultrasound as a first test, is could it be a DVT? So if the cyst is ruptured, it may cause some diffuse swelling and tenderness down the calf, so an ultrasound would be appropriate to differentiate the two. The other differential, of course, is it a soft tissue mass lesion, which an ultrasound will be able to differentiate, and if it is a solid mass lesion, then we would recommend an MRI. We also sometimes see them in babies. They are actually not that uncommon, but they usually resolve by the age of 2. The other thing to mention is that obviously if it is a sizable popliteal cyst, we can pop a needle in, take off the fluid, send it off if there's a reason to do so, and then put some steroid in. So just a reminder of the bursae around the knee, and all of these are very accessible to assess on ultrasound. So you've got the prepatellar bursa at the front, and then you've got the deep and the superficial infrapatellar bursae. You've got the suprapatellar bursa deep to the quadriceps tendon, and then round the back, the semimembranosus bursa or Baker's cyst. And the other one at the anteromedial aspect overlying the tibia is the Pezanserine bursa. So another case, 42-year-old came off a bike, has a swollen knee, query fracture. This is quite a straightforward case. You'll notice now with a trained eye, a lipohemarthrosis, and then a very complex lateral tibial plateau fracture. We did a CT to further characterize, and it shows multiple depressed bone fragments involving a large area of the articular margin, and it also propagates into the intercondylar region and also extends to the junction between the diaphysis and the metaphysis. So really significant injury, and this is very useful with the multiplanar and the 3D reconstruction for the orthopedic surgeon to plan surgery. Next case, 69-year-old knee injury, unable to weight bear or straight leg raise. And you'll notice on this, there's no fractures of the tibia or the femur, but on the lateral view, there is this irregular calcific density, which is suspicious for an avulsion injury. So the next test, as the patient is unable to straight leg raise, is an ultrasound. And what this showed was a full thickness, full width tear of the quadriceps tendon. You've got a big gap there, and also a hematoma. And this was enough to confirm the diagnosis and to then plan for the patient to go to theatre to do a primary repair. Next case, 68-year-old walking, felt a crunch and a pop in their knee and presented with a large swelling. So they've got a very large effusion here, possibly a fat fluid level, possibly. And so the query was, is it an extensor mechanism rupture? So an ultrasound was performed, but actually the extensor mechanism was intact. There was possibly some disruption of the deeper fibers of the quadriceps tendon, but nothing really gross. So the next appropriate test would be to do an MRI to further characterize. And this actually revealed that this was a patellar dislocation and rupture of the medial patellar femoral retinaculum. So you've got bone bruising in the patella and actually an impaction injury there. Next case, 14-year-old with 6 months of ongoing knee pain and intermittent swelling, but no history of trauma. So these are the plain films, and you've got what we call an immature or unfused skeleton here, which is appropriate for the patient age. Nothing really to see on plain film, no effusion, no avulsion injury. But the MRI shows this, which is quite intense bone marrow edema in the medial femoral condyle and also the subchondral bone of the medial tibial plateau. And on the T1 weighted sagittal, there is a linear low signal density, which is seen just below the articular surface. And this is actually an insufficiency fracture, what was previously called as zonk, which was called osteonecrosis of the knee, spontaneous osteonecrosis of the knee. But it's actually, in pathology terms, an insufficiency fracture. And it's very, very important to pick these up for two reasons. So from the orthopedic side, from the clinical side, is there a deficiency in the bone? So is there a weakness, an underlying weakness in the bone? Is there a bone mineral deficiency? Is there a vitamin D deficiency? From the radiology side, when we pick up these fractures, we have to question, is there a mechanical reason why this has happened? So is the meniscus behaving abnormally? Is there a problem with the load bearing during that in that compartment? So one of the things that we should look for is that, is there a meniscal root tear? Because if the meniscus is not behaving normally, there may be an absence of the proper load bearing. Next case, 29-year-old acute twisting injury playing hockey, swollen knee. And this case is a classic ACL rupture. You've got a posterolateral corner injury, which is very important to flag up to the orthopedic surgeon, because that could indicate a ligamentous injury. And if it's not picked up and clinically assessed, even though the ACL is repaired, it may lead to graft failure. 50-year-old PFJ instability, intermittent locking and swelling. Plain films are unremarkable, but this actually revealed multiple osteochondral injuries. And this shows a very irregular patellar contour here, and it's due to multiple recurrent dislocations, resulting in multiple osteochondral injuries and loose bodies. 31-year-old acute knee injury, swollen and locked knee. Whenever we see locked knee and you have that's in the clinical history, you've got to think of, is there a displaced bucket handle tear? And this one, you've got a displaced lateral meniscus, which is sitting here in the intercondylar notch. This I've just put in because it gives you a really good clinical history, and everything is in the history and examination. And the moment you read that history, you're thinking, is there ligamentous, meniscal, posterolateral corner damage? They're all of the things that I would be looking for on the MRI. Another bucket handle tear and also posterolateral corner injury. 34-year-old came off a motorbike. This case is really just to highlight, we've got an effusion here, but also a low density lesion, density lesion in the medial femoral condyle. And the CT revealed a fracture, but it's a pathological fracture through a bone marrow lesion, which was confirmed on MRI. So it's just something to think about in the background in your differential of a patient that presents. If there's a discorrelation between what they're complaining of and basic imaging, you do need to think about the more unusual causes, such as a bone marrow lesion, and particularly if you're an older patient or they've got a history of cancer. Plain film series, just something to remember that sometimes we don't always need to do an MRI, and there's enough information on the plain films. For example, if there's tricompartmental degenerate change, you don't necessarily need to do an MRI. Certain key phrases that you need to act on if you see in a radiology report. So lipohemarthrosis, it means that there's leaking bone marrow. You need to hunt for the fracture. So they need a further imaging test. If there's a flap tear, again, that's unstable. And that's something that the orthopod needs to be aware of. If you've got a flipped bucket handle, if you have an unstable osteochondral injury, that needs seeing to, otherwise that can lead to significant problems down the line. If there's an indeterminate soft tissue mass lesion that needs further workup, that may need further imaging. You need to discuss that with the radiologist or refer to a specialist center. An inflammatory arthropathy, that needs an appropriate workup with appropriate blood tests. And if you have a meniscal root tear or meniscocapsular separation. PRP injection, if you do refer a patient for this, this is a kind of rundown protocol that your patient needs to be aware of. You need to avoid taking non-steroidals a week before and 4 weeks after. The main reason being that this will inhibit the growth factor action that you're actually wanting to promote to result in regenerative healing. It's a procedure that's quite straightforward and doesn't usually cause much discomfort, but they do need to minimize their activity for a week after the injection, and again to avoid non-steroidals for about 4 weeks, and resume driving and usual activity within a week or so. So just to review, you should be confident now about what films to choose in the trauma setting. Horizontal beam lateral, OA series must be weight bearing. Ultrasound and CT provide a way of performing image guided procedures, and MRI you require for internal pathology of the knee. Thank you. So if we have any questions now, we can address those.
Thank you very much, Cynthia. I know Chinmay has gone through and answered a lot of the questions that have been put onto the questions and answers tab.
Thanks very much. I see there's some questions in the chat. Shall I address them? I'll start with the first question was, why is the diagnosis of patellar tendonitis important? Well, patellar tendonitis is a repetitive strain type condition, occurs particularly in jumpers. So we're talking about basketball players, netball players, runners sometimes get it as well. So where you're having high impact, and it's really a repeated microtrauma to the patellar tendon that results in an inflammatory response, causing quite a lot of anterior knee pain. And in catastrophic cases, which is rare, it can actually rupture the patellar tendon. I apologize. I hear that there are quite a few physiotherapists in our audience. So perhaps, some of you might want to comment on it, because the main treatment for patellar tendonitis is physiotherapy in the form of, well, initially you want to reduce the inflammation, but actually loading the tendon in the right way. Some people say eccentric loading, some people say loading with leg presses, and then really getting a graded return to sport. As I've mentioned, there is some role for PRP, and some practitioners also use shockwave therapy. Very rarely do we have to decompress the patellar tendon, but I've done so very successfully in really resistant cases. So that's patellar tendonitis, and the diagnosis is clinched really by the clinical examination, because the patient almost jumps off the bed when you palpate their proximal patellar tendon insertion into the patella. The next question was on sarcomas. So really, we talk about tumors. Tumors in the knee, in and around the knee, can be bony, like sarcoma, osteosarcoma, or soft tissue. They can be sarcomas of the muscle. They can also be of the lining. So you can get synovial sarcomas, or even giant cell tumors are a type of tumor. So really the red flags are night pain. So if in a child, the parents say she's not sleeping at night, we're having to give her paracetamol and Nurofen every night, that is not normal. Okay, there may be a psychological disturbance, but you really need to, that's a red flag. And we don't want to miss tumors in young people. And they're again, when I talked right at the beginning about people coming back with the same symptoms, if they come back third or fourth time, okay, they might be maligning, but actually that's a diagnosis of exclusion. So they need proper investigation with an MRI scan. So the classic red flag symptoms of rest pain, night pain, weight loss, lump, obviously, they're not easy. And when I have picked them up, I'd like to think it's really serendipity rather than skill. But it's important. So if something's not working out and the patient's genuine or their parents are genuine, you really need to rule it out. There are a couple of other questions which I've answered actually in the text, but perhaps I might I just need to go back to the chat. Q&A. I need to go back to the Q&A. I don't know how to do that. One of the delegates asked about, after an ACL reconstruction with a hamstring, people can have a hamstring deficit. Fortunately, this is not very common, but some people do get the hamstring. It's weird because the hamstring tendon actually regenerates, but in some people it doesn't, and it can leave a deficit. It's very difficult to treat. You can't really treat it surgically. The only thing I could suggest, if it's for pain, is sort of really good manipulative deep tissue massage, maybe some acupuncture. But if they've got a deficit, they've got a deficit, and you can't really surgically reconstruct that. What was the other one? There was another. Are one of the other panelists able to read out the
Chinmay, there is one about
Chinmay,
there is one about a unilateral swollen ankle formed after long distance walk, negative D-dimer, plain
Another
X-ray
question
negative.
was about custom-made knee replacement. Now, painful knee replacement is a topic in itself. It can be anything from malalignment of the knee replacement to early loosening to very low-grade infection to referred pain from the back or the hip. It really needs a full workup for someone who's had a painful total knee replacement, ideally by the surgeon who did it. If they wanted a second opinion, I actually don't do revision knee replacements, but obviously I could recommend someone who does. The last question was about septic arthritis and gout may present with similar symptoms. Yes, they can. Again, you've got to look at the clinical picture. So a high temperature greater than 39 degrees, a CRP of greater than 150, an ESR of greater than 50 or 60 is likely to be septic arthritis. In general, inflammatory arthritides give you slightly lower inflammatory markers and not so much of a high temperature. I think I've answered all the questions there. Are there any other questions in the chat?
I'm sorry if you just mute. Just regards to differentiating gout from septic arthritis, I mean, in terms of imaging, start basic with plain films because there are very classic features for gout. You know, you may see erosions or gouty tophi. Plain films are not good for picking up septic arthritis or osteomyelitis early. It's actually a very late pickup. So, you know, you definitely be looking more towards the history and examination. But if you've got a very high index of clinical suspicion and it doesn't look like gout on the plain film, then I would go to an MRI. And you can do both CT and MRI, but MRI would be most helpful. And if there's a break in the skin, so there's a route of entry for infection, then I would go to MRI. That would be the most helpful test.
So I'll give you mute. So there's a question here. How would you investigate a unilateral swollen ankle formed after a long distance walk? Negative D-dimers, plain X-ray negative, no response to flucloxacillin, but painful and color change to skin and peeling of skin. This sounds unusual, obviously. One would start to think about, I mean, someone's obviously thought about infection, but unusual infection. Particularly if it's skin, you wonder if they've been for a walk, is this a cellulitis because they've been bitten by something? Could it be Lyme disease? The other thing is it an unusual presentation of an autoimmune systemic disease like SLE or sclerosis? So it's very unusual, needs a full workup. If it's not settled after a week with some antibiotics, I think it needs full blood work. I don't know whether, Cynthia, you feel that it needs an MRI or an ultrasound.
If there is a focus, so a focal skin break, or you can feel a swelling that might be an abscess collection, you could start with an ultrasound. But actually an MRI would show all of that, the soft tissues, and if there is underlying joint pathology. So I think an MRI, if it's something that's been going on for a while, it would be appropriate to do an MRI.
Okay, there's some other Q&A questions. Why are some insurance companies don't cover PRP? Yeah, so, you know, the evidence base is, there is evidence for PRP. I think it's much better than for stem cells, particularly in tendinitis. When I look at the evidence in osteoarthritis, it shows equivalence to steroids or lubrication gel, but it's expensive. So what I say to patients when I'm counseling them is, the downsides of PRP are extremely low, but the biggest downside is it may not work and then you may feel like you've wasted your money. Now, some patients, it all depends on their risk-benefit analysis. Some patients say, well, look, if this is the least harmful thing and the worst thing that can happen is it doesn't work, I'm going to go for it. I don't care if it costs a couple of £1,000. Some people say, well, £2,000 compared with £300 for a lubrication gel injection, I'll go for the lubrication gel every time. So, you know, for the insurance companies, there isn't enough of a quality improvement in patients for the cost, but that doesn't necessarily mean it's not efficacious. The next question is, how common is IT band syndrome? I'm seeing a lot of it, in runners, in triathletes, and in cyclists. It's a combination of things: IT band tight, hamstrings tight, perhaps some lateral patellar tilting, weak gluteal muscles. Our physios will be nodding to that, I would imagine. So it's a difficult issue. It's very frustrating for those people who are really keen runners. There are some things, the physio is the mainstay of treatment, but there are other things that you can do. For example, shock waves or injectable ultrasound guided injections into the IT band. Very rarely I have actually released the IT band surgically. It's worked very well, but generally doesn't need to be done. Last question, 2 questions. 42-year-old female with a ski injury, ruptured her ACL, decided on physio rather than surgery. Now, this is classic, because what's happened is she's recovered really well, but then she's gone back to doing a twisting sport, which is badminton, and the knee has given way. Now medial plane and flicking sensation in the knee and uncomfortable walking. Is surgery needed ASAP? Well, she first of all needs an MRI scan, a new one, because I suspect what's happened is that her knee was unstable and she managed quite well with straight line activities, but it was always unstable. And she's gone to a pivoting activity. It's pivoted out of position, and now probably the meniscus is torn as well. Very classic. So she needs an MRI, and if the meniscus is torn and she's active and she's fit and young and not overweight, I would advise for an ACL reconstruction and meniscal surgery, ideally to repair it. Last question, how do you diagnose posterolateral corner on an MRI scan? I will hand you over.
Okay, so it's kind of beyond the scope of this talk, but really you're looking, first of all, is there clinical history indicative that they may have a posterolateral corner injury? For example, did they have a pivot shift injury, ACL rupture? You must look at the posterolateral corner, look for bone marrow bruising in the region of the posterolateral tibia and also deep to the sulcus terminalis. But essentially you're looking for, it's quite a complex area of anatomy with a combination of ligamentous structures. There's a whole list of them: arcuate, popliteal fibula, popliteus tendon. So you're looking for all of that checklist to see whether everything is as it should be. Is there increased fluid there? Are the popliteal meniscal fascicles intact? And also, is there a tear of the actual meniscus? Essentially, though, even if we pick up things on MRI, you're not treating the MRI, you're treating the patient. So what I would do is document that in the report, but actually communicate with the orthopod and say, look, there is evidence of posterolateral corner injury. Can you please clinically assess for posterolateral corner instability? Because if they do plan for an ACL repair, they need to make sure that those structures are addressed as well. Otherwise, they may fail long term.
I've over the last decade or so, I've been very aware of posterolateral corner injuries. I think if they're acute, you can see quite a lot of changes on the MRI scan. Probably a small minority of patients, between 5 or 10%, go on to have a chronic posterolateral corner injury. And really, a repeat MRI scan shows no major changes. And in fact, I did a posterolateral corner reconstruction on Tuesday with an ACL in a patient with a posterolateral corner injury, but it was a stretch injury. The point was that on clinical examination, it was grossly unstable. And so the posterolateral corner, I'm convinced, in a chronic case or someone who's had an injury more than a few months ago, is a clinical diagnosis that can only be supported partially with a radiology. And what I do in the posterolateral corner cases is examine them in the clinic rooms, but also examine them under anesthetic, because when they're under anesthetic, you can really stress the joint, compare with the other side. And I've prepared to do a posterolateral corner if they need one. So on Monday, I prepared for it, didn't need to do it, the patient was stable. On Tuesday, I prepared for it, did need to do it because the patient was unstable. But the key is the preparation.
Thank you very much, Chinmay and Cynthia. Really great talk. To everybody else, thank you very much